Our topic today is strengthening the care infrastructure in Illinois, economic justice, and long-term care. Last fall, we hosted in-person forums, and I say last fall, it seems much longer ago, but it was last fall. We were in person in Oregon and California, forums on this topic. This year, we've accommodated this situation we're in to virtual forums, which we've already conducted in Minnesota, California, and Michigan. Today's webinar focuses on the implications of universal long-term care on health and economic justice for older people, for people with disabilities, and for direct care workers. Last year, our Academy and Caring Across Generations released a comprehensive study of viable approaches for states interested in pursuing universal child care, paid family and medical leave, and long-term services and supports policies. In other words, a universal family care program based on the findings of an Academy study panel made up of 30 interdisciplinary experts. And thanks to the Ford Foundation, we're disseminating and discussing the study panel's report in virtual forums like today's. The information in this report is, I think, more important than ever as the COVID-19 pandemic and the economic catastrophe that has resulted continue to highlight the inadequacy and the inequality of our country's care infrastructure. When you look at what we have, which is the lack of an efficiently financed, well-functioning, and broadly accessible system of universal long-term services and supports, that lack is heavily burdening American families all across the country in unprecedented numbers. The economic contributions and quality of life of older people, of working age people with disabilities, and of caregivers themselves remain unnecessarily limited due to the lack of adequate services. Now, social insurance, in our view, represents a promising approach to meeting the challenges of ensuring broad access to these services and promoting the health and economic outlook for all of us who at some point in our lives will be caregivers, care receivers, or both. Now, we're not able to closed caption today's live discussion, but we will have a closed caption recording of our forum available on our website later this week. Just want to go over a couple of quick housekeeping notes. For those of you who are Zoom veterans, you know how this works. We want you to participate in today's dialogue by using the tools on your screen. You've got two ways to participate. You can type comments in the chat box, and you'll notice there's a chat now from one of our staff members. Or you can use the Q&A box for specific questions for the speakers or for other participants to consider. And both boxes are available on the menu at the bottom of your screen. We also welcome questions via email after you've watched the closed caption recording of the roundtable. The chat feature really lets us have a conversation. We'd like this to be as interactive as possible in the virtual environment. So please participate and make sure the recipients are all panelists and attendees. The default option is all panelists, but if you want the entire group who are joining us today to benefit from your comments, your questions, make sure you connect or click rather all panelists and attendees manually. Now, when the webinar ends, we hope to continue this discussion on our website. We have a section on the website on caregiving. It contains relevant work compiled by members and staff of our Academy, including the Universal Family Care Report that is the focus of this webinar. Now, we're very fortunate to have, to kick us off, a video from Representative Lauren Underwood, representing a district of Illinois, who is actually a practicing nurse. I believe she's the only practicing nurse who's in the House of Representatives. So let me turn to the comments that the Representative Underwood was able to make.
Hi, everybody. I'm Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. I'm excited to be joining the National Academy of Social Insurance for this timely conversation on Illinois' long-term care infrastructure. But before discussing any of the important policy issues that will be covered during today's webinar, I want to pause to solemnly acknowledge the deep pain that so many of you have experienced during this pandemic, especially those who've lost loved ones due to COVID-19. Yet for as difficult as the past 8 months have been, My hope is renewed every day when I see the ways that our communities have come together. There are essential workers in nursing homes who have cared for their residents as if they were family. Small business owners who have adapted public health guidelines with creative solutions to continue serving the food we all love. And healthcare workers who made heavy sacrifices on the front lines of the fight against this virus. I'm inspired by the resiliency of our community, and I'm committed to doing everything that I can in Congress to ensure that we emerge from this pandemic stronger than ever. To do that, we need to make robust health and economic investments, strengthening our public health infrastructure, expanding the healthcare workforce, and providing direct financial relief that individuals and families are relying on. And as we act to save lives and livelihoods, it's imperative that we prioritize our neighbors who have been most severely impacted by COVID-19: seniors, people with disabilities, and direct care workers. Although every age demographic is at risk for contracting the virus, older adults face disproportionate levels of risk for severe illness. In fact, Americans over 65 represent nearly 80% of coronavirus deaths in the United States. We also know that people with disabilities face elevated risks due to COVID-19 from both social, economic, and health factors, including underlying health conditions and living arrangements in congregate settings. And finally, we know that the workers who care for our most vulnerable populations face higher risk for contracting COVID-19. These trends drive many of the glaring racial and ethnic disparities that emerged at the beginning of the pandemic and have only worsened in subsequent months. More than half of direct care workers are people of color, and most of these workers are women. Data from the Centers for Disease Control and Prevention also show that Black and Hispanic Americans are 4.5 times as likely to be hospitalized from COVID-19 as white Americans. If we want to address the key drivers of adverse outcomes from COVID-19 and these stark disparities, then we must advance policies to protect residents and workers in long-term care facilities during the coronavirus pandemic and beyond. One bill I've championed with my Illinois colleague, Congresswoman Jan Schakowsky, is the Bicameral Quality Care for Nursing Home Residents and Workers During COVID-19 Act. This bill would protect the health and well-being of those living and working in nursing homes by increasing infection control and prevention, expanding testing, securing personal protective equipment, sending strike teams to the hardest hit nursing homes, mandating transparency and reporting of COVID-19 cases and fatalities, and requiring the Centers for Medicare and Medicaid Services to conduct better oversight of these facilities. We also know that healthcare costs, which were already crippling for so many Americans before the pandemic, are even more urgent of a concern now. And that's why I've championed the Affordable Insulin for the COVID-19 Emergency Act, which would require that seniors who are enrolled in Medicare Part D prescription drug plans be able to obtain insulin and associated medical supplies to manage their diabetes without facing any out-of-pocket costs during the COVID-19 emergency. The bill would also ensure that Medicare beneficiaries can obtain a 90-day supply of insulin by mail without the additional risk of going to a pharmacy. And finally, I've co-sponsored legislation to ensure that long-term care facility residents can stay connected with their loved ones and family members using digital technologies and other legislation to improve quality of care and safety measures in long-term care facilities through funding infection control enhancements during this pandemic and into the future. Because for as much as we need to focus on COVID-19 now, it's also critically important that we think about policy solutions to permanently strengthen Illinois' long-term care infrastructure. We need to think boldly, advancing ideas that will promote both clinical excellence and quality and equity. I know that the speakers who will be participating in this panel discussion will share many of these innovative ideas, and I hope that you have a great conversation. Thank you again for the opportunity to join you today. I look forward to being together in person again soon, but until then, take good care of yourselves, everybody. Bye-bye.
Good afternoon, everyone. First, thank you to the National Academy of Social Insurance and Caring Across Generations for hosting and sponsoring today's event on a topic of critical importance. I'm thrilled to moderate this event and excited to engage with all of you. I'm Marci Ybarra, as mentioned, and I'm an associate professor at the School of Social Service Administration at the University of Chicago. I'm really excited to learn with and from the stellar lineup of panelists today. And before we move on to our discussion part of the event, I'm going to first introduce that stellar panel. Meg Cooch is the executive director of the ARC Illinois. She has almost 20 years of nonprofit experience and brings a passion for disability, aging, and health policy, advocacy, and organizing with her to the ARC of Illinois. Most recently, Meg served as the first executive director of the Illinois State Alliance of YMCAs, overseeing the development of the organization and leading the state public policy efforts and program initiatives. Prior to moving to Chicago, Meg worked on the federal level disability policy in DC as the Director of Policy and Advocacy for Lutheran Services in the American Disability Network, and as the Deputy Field Director for the Alliance for Retired Americans. Meg also has local experience working directly with individuals with disabilities, seniors, families, and service providers at Planning for Elders, a grassroots San Francisco-based advocacy organization where she worked in many capacities, including as Executive Director. Next is MaryBeth Linse. She describes herself as a mom of a special needs child and has been a chiropractor since before her child was born. She now teaches biology at McHenry County College. She's an active member in both the SEIU, or the Services Employees International Union, and IEA, the Illinois Education Association. Uchachi Mitchell is an assistant professor of community health sciences at the School of Public Health at the University of Illinois, Chicago. She is a National Institute on Aging postdoctoral fellow at the University of Southern California Center for Bioimmunography and Population Health. She received her PhD in public health with training in community health sciences from the University of California in 2014. Mitchell's research investigates racial, ethnic, gender, and economic inequities in health and aging. She examines the psychosocial and biological pathways leading to these systemic differences, with a specific emphasis on the role of social and psychological stressors. Current projects include research on social and age-related disparities and inflammation, and racial disparities and cumulative biological risk and disease onset. Christina Warden is an expert on strategies to help working and adult students earn their GED and succeed in college. She leads Women Employed's education and training team to ensure that more low-skilled Illinoisans earn credentials of economic value. She manages Women Employed's partnership with City Colleges of Chicago to help low-skilled adults access education and career pathways, and her efforts have helped to increase supports for non-traditional students and improved educational pathways, leading to better quality, better paying jobs for working women. Warden came to Women Employed in 2007 with 20 years of experience as an advocate and strategist for improving public K-12 education. In that capacity, she built a national network of school reform leaders focused on changing management practices in order to improve conditions for students in public schools and support the work of teachers in the classroom. I'm an associate professor at the University of Chicago, as I've already mentioned. I do some work on paid family leave, but the focus is mostly around time of a birth and also childcare. So I'm excited to learn from the panelists, as this is not my area of expertise, and also to moderate the session and take Q&As. If you could drop your questions that you might have into the Q&A section, then I will pull from those when we get to our discussion section. Next, I think we can move on to the next slide that highlights the discussion section of the program. Thank you for pulling that up so efficiently. So the first slide is really us wanting to provide a foundation for all of us to work from today with a shared understanding of what we mean by universal long-term care. A universal long-term care program is state-based social insurance to help individuals and families pay for long-term services and supports without having to exhaust all of their personal resources in order to access care. Many people will not have any need for long-term care services and supports. Others will have need for moderate durations, and a small number will face catastrophic expenses. As a result, the need for long-term care services and support is difficult to plan for, but it also threatens retirement security and is well suited to risk pooling through a social insurance program. Social insurance program is actually a really efficient way to mitigate the financial risks associated with long-term support care and services. A social insurance program pool risk broadly across a population, often society as a whole. In this system, everyone contributes to a state insurance plan through a dedicated revenue system, which typically has included a fixed percentage of earnings from workers, as is the case with Social Security and Medicare. And everyone who contributes is eligible for benefits. Policymakers in Illinois can choose from a variety of options in structuring a new social insurance program for long-term care. Next slide, please. Oh, I'm sorry, the Zoom mistakes of starting with the second slide instead of the first slide. My apologies. What does Illinois provide thus far, or what do we provide in general in the US? This slide lays out the general average costs of long-term care in the US, which reveal many disparities and gaping holes. You can see from the slide that on average, long-term care services and support for half of Americans who will have significant long-term care needs in old age is over $250,000. This is exacerbated by many families who already struggle with financial burden, as reflected in the total retirement savings on average of $10,000. And even access to Medicaid for long-term care is fragmented. The middle class isn't eligible and depend on it long-term care services supports for their well-being. And private long-term care insurance hasn't turned out to be a panacea or a widespread solution, as only about 7% of folks in the US actually have private long-term care insurance. Thank you. Actually, I think it might be good to move to the discussion slide number 3, since I flipped 1 and 2, if that's possible. Thank you. So this moves us to our discussion section. And this slide is an overview of the benefits of a universal long-term program for various stakeholders. We're going to focus on the impacts of Illinoisans. I'm going to always have a hard time saying that word, so forgive me. To get us started off on the discussion piece, to talk through a little bit about what a long-term care services support program can do is it can help people living with disabilities actually stay in their communities. It will allow families to keep their loved ones at home if that is the best solution for them, as determined by them in their medical care. And for insurers, it would provide a significant boost to private insurance as public awareness increases. It would bolster the care economy, which, if in this moment or this pandemic era hasn't highlighted the need to bolster that support, I'm not sure what will. It also enables workers who are family caregivers to work full-time and pursue careers, as they might be able to better afford outside care to come into the home. And for states, it reduces medical long-term care spending, among other things. So I thought we would start off here with beginning with the panel and asking, how could a universal long-term care system promote economic justice for older individuals and people with disabilities? What would the implications for direct care providers and family care networkers be? And what would be the implications for women and families? And I think to kick us off, it would be nice to start with Uchechi on this.
Great. Thank you so much, Marci. Excuse me, and thank you to the National Academy of Social Insurance for having me here. So I'm going to approach this question from the perspective of thinking about social and structural determinants of healthy aging, specifically focusing on racial health inequities. And what we know about our current system is that the low wages and poor compensation that our home care workers receive has a ripple effect, not only among for them, but also for the families that are in need of care and the families that are caring for somebody that they love. So in this space, the lack of having a universal long-term services and supports only exacerbates the racial health inequities that we are currently seeing. So for those adults who are struggling with chronic conditions that need care, they can't afford the care that they need and may not therefore get adequate care, which can lead to accelerated declines in health. For the family members of elders of color in particular, where informal caregiving is very culturally embedded within those groups, it may lead to them having job insecurity and missing work to take care of family members. And that also compromises their work stability and also puts an increased stress burden along these caretakers that they don't have many resources to use to cope with. And then for the home care workers themselves, as we've heard, who are primarily women and primarily people of color, they themselves are suffering from low pay, low benefits. And so once they're older, they wouldn't have accumulated enough resources, financial resources, to provide care for themselves anyway. So what we see is that this is a cycle of familial and intergenerational social and economic disadvantage that can lead to the perpetuation of racial health inequities, right? So in that space, thinking about what we can do to alleviate some of these issues is, frankly, to pass long-term care support services and supports. And that takes a shift in how we think about who is, quote, entitled to these services and shift it to more of a rights-based type of perspective when it comes to these services, and just changing our underlying philosophies about the way we care for those who are caring for the least among us.
Thank you, Uchechi, for that really lovely and descriptive, nuanced answer. MaryBeth, do you have something to add?
Just that since I've been taking care of my daughter, my daughter is a ventilator dependent quadriplegic, and we take care of her at home. We did have her in a long-term care facility, and we found that they were not able to take care of her. They were understaffed. There were only 2 long-term care facilities that even took ventilator patients. While she was there, she was basically ignored because she was alert, and most of their ventilator patients were unconscious. So because she was alert and on a ventilator, many times when I would go in, I would find her completely left alone and not being cared for, crying. She actually came out of the long-term care facility after 3 weeks with a type of PTSD where she wouldn't let anyone come by her except me. So yes, we need something that supports people and lets them bring their family home, and supports the long-term care facilities to bring them out of being just for profit, where there's not enough. There were literally 2 nurses for 80 patients on the floor that we were on. They had ventilator dependent patients mixed in with regular patients. So the regular patients were getting cared for because they were louder than the ventilator patients. And if a ventilator patient had to go to the hospital or somebody was being admitted, all the other patients were being ignored. So it was incredible while she was there. It was very, very traumatic. Thank you.
MaryBeth, thank you so much for sharing that deeply personal story in highlighting the huge gaps in services we currently have, and how important it is for all families, and particularly families with those who need care. And Christina.
Sure. Thank you, Marci. I wanted to focus a little bit on the gender lens on this issue. Because as you say, and as the slide in front of us says, long-term care social insurance program will allow, seniors, people with disabilities, to age in place and stay in their communities, and families to have the security and the peace of mind of knowing that those family members are well taken care of, which both impacts the individuals who are in that situation, but it also has a a preponderance of the impact is on women because in our culture, women are still primary caretakers in our family, in our families. And as Uchechi so eloquently said, many of those women, whether they are paid caretakers, so that is their work, or they are family caretakers, so that is unpaid work, if they're in the workforce, they're receiving low wages, they have poor benefits, they often have high turnover rates just because of the care requirements. I have seen research that estimates that family caregivers spend anywhere from 17 to 26 hours a week just on caretaking responsibilities. And if they are also in the workforce, that means that you have a full-time job in the traditional economy, you have a part-time job as a family caretaker, and then you have all your other responsibilities above and beyond that. And this also, not only does it predominantly fall to women to be the caretakers, it also predominantly falls to women of color to be caretakers in their family. And because of racism and racial biases in the economy, those women who are often head of households just do not have the family wealth accumulation that provides for additional supports beyond their own time and their own caretaking. But one of the things we focus on at Women Employed is that this reduces the ability of those women as workers. It reduces their lifetime wages. It reduces their pension contributions if they have high turnover or if they are unable to participate in the workforce because of their caretaking responsibilities. It impacts their contributions to Social Security. They lose opportunities for raises, for promotions. Their ability to save for retirement. So there are ongoing and long-term impacts, both for those who need care, but also for those who are providing care. I think those, as I said, those negative impacts will be felt for years to come unless there is a proactive intervention. And the proposal that it's being put on the table here is that long-term intervention to provide supports both for those needing care and those who are caretakers.
Wonderful. Thank you to all the panelists for that. My big takeaway from hearing you all speak is the importance of understanding the baked-in disparities or structural biases we have in the larger labor market that affects not only caregivers, but also those who need care. And that is not only important in the near term for when they need to provide care, but over the long term in terms of economic mobility for the individual, both providing care and receiving care, and that is usually highly concentrated. It's important for all families, but the effects of that, the negative effects of that are much more highly concentrated among racially underrepresented groups and their loved ones, and also concentrated in the labor market for disparities in low wage work as well, further complicating the picture. I had one follow-up question on this, which was, if anyone would like to speak to it, is from your view, how has the pandemic reshaped or shaped the current things that you were talking about with long-term care and the need for it?
May I? Hi there. Thank you for having me as well. The ARC where I work, it works with people with intellectual and developmental disabilities and their families. And so I think the folks before me have spoken eloquently on the family side. And in Illinois, about 72% of people with intellectual and developmental disabilities live with their families. So I echo everything that's been said. I think the other, one of the key things and what I'm really excited about this idea is the idea of people staying at home and in the community. And I think the pandemic, if anything, has very much highlighted the challenges with congregate living. And in Illinois, we tend to skew larger and more congregate, unfortunately, in our investment in services, in particularly home and community-based services. And so this is a well-timed, because I think this provides a significant alternative potentially so that folks might be able to utilize this before having to make decisions that move people into more congregate settings. In Illinois, right now, you've seen, as many other places, nursing homes with much higher rates of COVID. In institutions, state institutions for people with IDD also have very high rates of COVID. And I think from our family perspective here, I think not only is it a concern for health, but it's also a concern for isolation. You know, folks in nursing homes have not been able to see family since March, and people, same with folks with IDD, and that is a huge issue around, that impacts people and their health and well-being, and we're incredibly concerned about that. So, you know, the idea of being able to have flexibility and keep people at home in communities, in smaller situations where they can have one-on-one support or small group support, I think becomes even more important right now.
Thanks so much for that, Meg. Really bringing to the forefront the importance of considering folks who are living in those settings. Do any of the other panelists have thoughts or perspectives on the effect of the pandemic on this area? MaryBeth, did you raise your hand?
Yes, I did. Thank you, Marci. With us, it's been much more difficult traveling around because of the pandemic. So we've been doing a lot more video conferencing with doctors and stuff like that because of just a fear of going in the office. I mean, when she goes in, we have to go in through a back door. We can't be in the waiting room because she is on a ventilator. There are so many things we can't do. Having people come in and out of the house, having people come in and out, they have to wear masks. So, I mean, there has been a lot more stuff with the pandemic than it had been before. Thank you.
Thank you so much for that. I wanted to interject with one. I have two questions from the audience, but the first one is a clarifying one, which I think would be good before we move on to the next set of questions. Richard Kaplan asks, caregivers versus caretakers, are these terms interchangeable? And if not, please elucidate the difference. Would anyone like to tackle that among our panelists? I will say that I use them interchangeably and have no idea if that's actually correct. Uchechi, I saw that you unmuted yourself.
I was going to say the same. Excuse me. At least in the literature that I've seen, it's interchangeable: caregiver, caretaker. And I don't know when the shift happened, but I do think they're signifying the same thing. This is an individual caring for somebody else. So I do use the terms interchangeably.
Okay, great. Then we're going to agree for the purposes of this event. We are using those terms interchangeably and don't mean a substantive difference. Thank you, Uchechi. And thank you for the question, Richard. And I know that you have another one that we'll get to in a minute because it dovetails on the next question I have for our panelists, which is in thinking about, we talked a lot about the importance of long-term care for across the family spectrum in the US and in folks who need it. How does the current long-term services and support system in Illinois exacerbate poverty and economic security from your perspective, experience, or research?
Sure. I mean, I think it's very similar to what I was saying previously about this cycle of disadvantage that can be created because people can't afford the care that they need and therefore don't receive the care that they need. And that doesn't only just affect the individual, it affects their families and it affects the people that are providing care. So it's double or even triple jeopardy when you're thinking about race and age and even disability on top of that. Because those who are most vulnerable are not receiving the care that they need. And I do want to note that something that occurred to me, that we're talking about a workforce that's predominantly female, that's predominantly racial, people of color. And it's not surprising to some extent that they tend to be underpaid and have poor compensation for their work in terms of thinking about how race and gender have operated within the US. So talking about these prejudices and these stereotypes, they historically, these groups have been undervalued in general. And so in this workforce, they are also undervalued. And that is why we are having this conversation right now about, should we place greater value among these people providing care? Because the way the system is right now, you have to have disposable income in order to get the care that you need, as opposed to it being something that's affordable for everybody. And so it kind of boggles my mind. I know there are cost considerations and financing considerations that people put forth, but from my perspective as somebody who specifically focuses on health equity and the role that these systems and structures play in either preventing or supporting health equity, I do think it comes from our philosophical ideologies in terms of, who do we value? Who do we think is worthy, because that's the word that's kind of comes to mind, of this care and services, and are we willing to provide it? So in terms of this exacerbation of racial and economic inequities, it's the low income, it's the racial and ethnic minorities, it's women, it's immigrant communities that are consistently undervalued. And we see that reflected in the healthcare that they receive. We see that reflected in the incomes that they get paid. And this is just another microcosm of that being exacerbated both within the long-term care setting, as also in terms of what we're seeing in terms of how COVID-19 has disproportionately affected some of these groups. Thank you.
Thank you, Uchechi. I was wondering if MaryBeth, given your own personal on-the-ground experience, if you had any thoughts on the ways in which Illinois' lack of a long-term care services system has exacerbated things for you and your family.
The biggest thing that I have found is the inability to even navigate the system that exists. The system that exists is so incredibly complicated. And then they decide, I mean, my daughter literally recently switched from Medicaid to Medicare because she became eligible for the Medicare program. First of all, managed care was a nightmare. That was last year. Complete nightmare, fighting insurance companies constantly for her medication. And then Medicare comes in, we have to start over. She has to see every doctor all over again. None of the 23 years that she's been on the earth mattered for all the records. We had to start over. And they're like, oh, well, she can't have that medication, and she can't have that medication, and she can't have that medication. And there are certain medications that she gets because they're deliverable. For instance, she gets an inhaled steroid. That has to be an aerosol. It can't be a powder. Most inhaled steroids now have been switched to powders. And so you cannot give a powder through a ventilator. Okay, it's just impossible. But letting insurance companies know this, impossible. Another thing is she got a medication called Pulmazine. Pulmazine is used for CF patients usually. In this case, they use it for her because of the blockages she gets in her lungs. Because it wasn't priority, that kind of, they now refused it for a second time. First the managed care refused it, and I fought them, and now Medicare refuses it. So, I mean, just the navigation of the systems is insane to begin with. So bringing some simplicity and some understanding, I can't imagine what it would be like for people who do not have a healthcare background navigating these systems. I'm fortunate that I do have a healthcare background, but without a healthcare background, I can't imagine how people are navigating these systems and actually know what to do, especially with COVID, now that we can't go to the offices and ask questions. So thank you.
Thank you so much for sharing that, MaryBeth, and really highlighting what families have to go through even when they have access on paper, have access to care. It's still incredibly complicated, and that only adds to a family stress. We appreciate you. Meg?
I think in addition to that, I guess I would say two things. One is income and asset limits. So what we have available to most people, in fact, is Medicaid, which requires people to really spend down and to not have a safety net in the bank if anything happens. And so, especially for folks with disabilities, that means that if you do wind up getting employment and are employed, you can't get too good at a job, or, you know, we're running into issues right now with the increasing minimum wage. How wonderful that is that we're getting better on the minimum amount we're willing to pay people. And yet then you start running up against income and asset limits that really mean the difference between that people being able to stay in the home and in communities and receive home and community-based services. And so that's, I think, a huge issue that continues. So the idea of an additional benefit that would allow people to make some more money and to be able to contribute and be a part of the employment world and be able to still receive some benefits, I think would be critical. The other thing is, even for those supports, even if you're willing and able to have the assets and income limits to qualify, right now for some services, there's a waiting list in Illinois for people with intellectual and developmental disabilities. It's about 5 years. So to be able to, again, have access to an alternative, even if eventually you want and need more support than what is available through an insurance product, it would allow for something. Because right now, kids at 22 hit a cliff, and at least in the IDD world, and that's a huge problem.
Thank you, Meg. I have a follow-up question. Can you share with us, for the audience, what the asset limits are?
Well, depending on the program and how old you are, you know, we come across folks that have the income limit is a little over $1,000. It's, I think, someone can correct me if I'm wrong, but 1,063, at least in the realm I'm in, and it's about a $2,000 asset limit, depending on which program. There are some programs that do allow for higher asset limits. And there is a product nationally, the ABLE program, that allows people to put aside money, but it's a very restricted program for kids that have had their disability before the age of 26. So for a lot of folks, it's not a way to be able to set aside your assets and avoid that issue.
Great, thanks for sharing that. I think it's really critical that folks know when we say asset limits that we mean pretty meager assets in the big scheme of things. So thank you for that. I'm going to move to Christina on this, but before I do, I wanted to make a pitch to the audience that from 2:45 to 3, it's going to be the Q&As from the audience. So if you have burning questions, please feel free to drop them in the Q&A, and I will do my best to get to them. So thank you. Christina, did you have experiences at Women Employed in sorting out what the big gaps in Illinois are for the women that you represent?
Well, there are some pretty serious job quality issues, which affect most of the workers in the caregiving industry. And those are issues that Women Employed does and has worked on for a very long time. We are currently in a push to ensure that there are paid sick days in Illinois. I can't imagine a time where it was more obvious to almost everyone that we need paid sick days during the time of this pandemic. Have been very involved in the work around minimum wage. And, Meg talked a little earlier about economic mobility. And we push very hard for women to have both economic opportunities in the workplace, but also educational opportunities that will allow them to advance economically. And you're sort of working against yourself when you have the kind of income limits that Meg is talking about, which seem to mandate that people stay in the low-wage workforce and that they do not advance economically, because if they do, they lose access to services and greatly needed services. One of the other things, though, that I wanted to raise here, because we've talked a lot about just the devastating impact on individuals who need the service and their families, and those who are caregivers, but also in Illinois as an economy. If we want to have a healthy economy in Illinois, we cannot have a situation where a large part of our population is not allowed to participate in the labor force because they either need to be caregivers, because there are income limits in order for them or their family to receive the resources that they need. Many of these individuals, as I said, also cannot participate in higher education. They don't have the wherewithal either financially or in terms of their time availability to get the education that they need to advance in their career. And that means that they're not contributing to our economy. They're not earning an income that can be funneled back into the economy and keep the state healthy. So I think there's a compelling reason for women, particularly for women of color, but for us as a state as a whole, to ensure that these individuals have the capacity to be active participants in our economy. And the situation that we are in right now without a long-term care insurance program in Illinois means that we are systemically cutting those individuals out of the economy in Illinois.
Thank you so much to all of our panelists for giving your thoughts on that. I'm sure there are many other things we could talk about in terms of gaps in service, and the pandemic has only exacerbated and highlighted all of the things that you all have mentioned, and we appreciate that. Unless there's any further comments on the prior questions from the panelists, I'm going to try and shift to Q&As from the audience. We've had several that have come in. Is that all right with all the panelists? Perfect, great. So our first question is from, sorry, y'all, I'm navigating my technology. So let's see. So here's a really good, big, broad question that I think is really important. We've seen Washington State move on this issue. This is from Kathy Hurwitz. I'm not sure if I'm pronouncing that correctly. We've seen Washington State move on this issue. Is there an ongoing discussion in Illinois about how to move to a long-term care services and support insurance policy?
So I believe, this is Meg, I believe that there is a study that was passed in legislation that is currently ongoing to look at what that could look like and how it could be structured. I don't have much on that, but I do believe legislation passed this last year to make that move.
Well, thanks for that, Meg. I wasn't aware of that. Does anyone else on the panel have an idea? I think the essence of this question is how do we move beyond a seminar that gives us a wonderful foundation and information into advocacy and eventually change? And that's a big question. So please, if you have thoughts, feel free to contribute.
Well, I would just add to what Meg says. I think building off the results of that study, once it's available, that puts us in a position to really have a strong push in 2021 for a statewide system.
I would also just, I think that's absolutely right. And I think that that post-pandemic time is a really critical time to have this discussion, because I think it has really opened people's eyes to the challenges of caregiving really throughout the lifespan, let's be honest right now. And that I think there's a great opportunity with that study. Hopefully there'll be some strong numbers, as well as I think we as a state need to continue to look to other states and learn from what they're doing. And I think that's great that Washington might have some examples that we can move forward on, but that would be the hope. I totally agree with you, 2021.
Wonderful, thank you. We have another question. Oh, this is an interesting question, more of a request to comment. Please comment on the Biden care plan and how it intersects or doesn't with what's being put forward as long-term care services social insurance program.
So I'd like to comment on the Biden care plan. What it does is it increases the acknowledgement of the personal assistants and the people who work at home. It looks to giving us benefits. It looks to giving us a living wage that we can actually survive from, and it looks for giving us retirement. And it also looks to increase the amount that is given to the states, as well as Illinois, as well as all of the states, and increasing, just bringing people home and keeping them out of care, which our state needs so much, because our governor, previous to our Governor Pritzker, obviously was more into putting people into nursing homes. And so I really think that we need to bring people home, and we need to really take care of the people who take care of our most delicate people at home.
Thank you, MaryBeth. Did any other panelists have comments on the Biden plan versus what's being proposed? I think MaryBeth, for me, I echo your same points, MaryBeth, in that there's a lot of overlap, and the gist of the Biden care plan, I think, aligns very well in terms of keeping folks in communities rather than institutionalized care, and that's a major piece of it. One other question from the audience. Healthcare is supposedly one of the major issues in the upcoming election, but long-term care services and support does not seem to be on the public policy agenda. Why is that? And I think this is more of a national question. Why is that, and what will it take to change, and how has the COVID crisis affected? Well, we've talked about COVID, so we'll put that on the side. But in thinking about major issues, is how do we get this on the policy agenda, and why hasn't it been there before?
So this is Meg. I think what I would say is I think there are very strong advocates, including the folks who put this together, who have been trying to get it on the radar. Long-term care is expensive, and so I think there is sometimes, even during when the ACA conversations, there were folks madly trying to get long-term care, and particularly home and community-based services funded through that, and really try to eliminate that institutional bias. And it can be a high dollar. I think the efforts and the creation and ideas around a pay-in insurance program helps to defray that cost, as opposed to just expanding or removing the institutional bias on the Medicaid side. So I think there's some opportunities. I think there's been additional work done on how we could possibly expand and diversify the home and community-based service space and supporting family caregivers in that space. So I think, as opposed to a few years ago when there were maybe less options and alternatives, and I think it's really organized, and it comes to family caregivers, people with disabilities, seniors, and advocacy groups coming together to really demand, if there is a new administration, the new administration really pushing this up to the top of their agenda.
Great, thank you. Anyone else? I'm thinking, not to put anyone on the spot, but Christina, given you lead Women Employed, I'm assuming you're deep into the policy issues. Do you have any thoughts on this?
Absolutely. I was just about to unmute when Meg was finished. I would echo everything that Meg just said, but one of the things that is the most troubling, and part of the reason that I think the specific issue isn't on the national agenda right now, is that unfortunately we find ourselves in a position right now where we're having a debate about whether healthcare in general is a right for all or just a privilege for a few. And I think when you're having debates that are at that level, it is difficult to move issues onto the policy agenda, which fall underneath that umbrella. And I will just take this moment to say it is so important that anyone who has not voted yet either turns in their mail-in ballot, gets to the poll to early vote before Election Day, or gets to the poll on Election Day, because we're not just making a decision between candidates, and I'm not going to support any particular candidate in my comments here, but we're making decisions on very important issues that affect the lives of ourselves, our family, our neighbors, and even those neighbors who may not sit next door, but who are neighbors in our state and our nation. And it is so important that we make decisions on these higher level policy issues so that we can get to issues of long-term care, et cetera, and the biases that go into the reasons why we lack that right now.
I just wanted to chime in because, Christina, that was exactly what I wanted to say. It really goes into what and who we choose to value in society, right? And I'm in public health, and the debate about health being a right versus a privilege has been longstanding. And of course, I'm on the side that it is a basic human right. And we have the capability to provide it for everyone, but we choose not to. I do understand we have to deal with economics and financing, and that all plays a role. But in my viewpoint, and this is a high level viewpoint, that does not warrant the sacrificing of human lives for balancing a budget, right? And the failure to see the long-term benefits of investing in people's health prior to these stages of health decline. We're seeing that now. Prevention is key. We've done a poor job preventing the spread of the COVID-19 right now, and we're going to face a lot of economic repercussions because of it, right? And so I think the same thing applies to the way that we care for older adults, the way that we care for those with disabilities, the way that we care for people who are who may be more vulnerable to poor health, right? And so who do we value? Who do we choose to support? And what are we willing to give to those people so that they can live healthy and fully functioning lives? It's a very large question that we as a society have to address.
Thank you so much for that, Uchechi. We can't forget that so much of this has to do with political will and how we extend care through policy. Not, yes, that was an intentional pun on long-term care if you didn't catch that. But so wonderful comments, and I'm going to transition to probably our final question, given our time frame. We're at 2:57 and we want to end in 3 minutes. But there's a question about long-term care being left out of the ACA, largely because of the actuarial concerns. How will this be corrected if a national plan is put into place? I think this is the point that others made earlier about long-term care. For the small share who need it for catastrophic injuries or for longer-term care, the costs are really high. So how do we reconcile that with a long-term care social insurance program?
I will just say I know nothing about the actuarial process, so it's hard to say what the concern actually was. But frankly, I'm not positive what to do. So I put that out there only because it is going again back to, can we or do we choose to finance these programs, is what I see the underlying foundational driver of these decisions. And you can calculate things so many different ways. I mean, this is part of my work. You can calculate it and say, yes, we should support this policy, take the same data and do some calculations and say no. Not to say that it's completely arbitrary, but to say that, again, it comes back to that political will to muster up the funds, which we are able to do so if we really choose to or try to. So I don't have any technical response around this question, but I still go back to the philosophy and the values that we have put forth when we put these policies together.
Wonderful, thank you. Do any of the panelists have any final thoughts on the question that was just asked before we wrap up? Okay, so that concludes our discussion and answer section of the program. I was thrilled to talk with all of you and learn from you and understand even more how complicated this is, but also how critically important it is. So thank you to all of you who participated and to everyone who showed up today for the Zoom. I know we're all Zoomed out, and so we tend to show up for things we really care about, and your questions clearly demonstrated that. So thank you very much. We're going to transition back to Bill, and he will close us out. Thank you, everyone.
Marci, thank you, and Meg and MaryBeth, Christina, Uchechi, thank you also for a stimulating discussion. I've been on all of these forums. You learn something new every time, and in this case, the nuances, as Marci said, are critical, especially at a time like this. I couldn't help, in response to the last question about the actuarial cost estimates, I spent the first part of my career at an actuarial consulting firm, and we soon realized that if you ask an engineer how much 1 + 1 is, the engineers will say it's exactly 2. You ask a lawyer how much is 1 + 1, the lawyer will say it's usually 2, but there could be exceptions. When you ask an actuary how much 1 + 1 is, the actuary says, how much do you want it to be? So there's some aspects of the technique and the technicality of all this that is more subjective than you might think. We also mentioned the fact that we're in a national campaign and a conversation. Tonight's the last debate. There is a section in the debate called the American Family. And I hope, all of us hope this issue will finally get to the debate stage where it can be front and center because of the effect it's having on so many of our lives. So thank you again. For those of you who are participating, thank you for your involvement. You'll all get an email following this asking you to just take a brief survey. We relish feedback, and it helps us plan future activities in the universal family care space. Clearly, we're dealing with enormously uncertain times. So our hearts go out to all who have suffered, whether it's from the pandemic, from the economic catastrophe, from the racial violence that we're facing as a country. Let us hope that we can look back and become better because of all of this. So thank you again for your time. Most importantly, please stay safe and stay healthy. Bye-bye.